Disc 2 concludes with a discussion Robert Vogel had with Dr. Michael Criqui, Distinguished Professor of Preventive Medicine at the University of California, San Diego, on why the ABI is a potent CVD risk predictor, 2 decades of critical research.
Welcome to ACCEL, Mike.
Thank you.
The ABI is one of the original biomarkers, and yet I think there are evolving data that probably advance its use. So tell us what's new. What is the ABI and how do we measure it?
The ankle brachial index is simply the ratio of the blood pressure at your ankle to the blood pressure in your arm. Normally that number ought to be above 1. And now we know if it's below 1, it's a cause for concern. And the lower it is, the more cause there is for concern.
So no more 0.9 as the cutoff.
0.9 is the traditional cutoff. What we've learned is that people between 0.9 and 1.0 often turn out to have PAD. People often have a rest normal ABI, if you will, but with exercise, the ABI will often decrease 20-30%, and we know that's evidence of ischemia.
What about people with a high ABI?
An ABI is considered normal up to about 1.40. Above 1.40, you can't really get a ratio that high physiologically, so you know there's something else going on. And what's going on is there's calcium in the media of the arteries, which is making the artery stiff. So you're trying to compress the hydraulic blood pressure in the leg, but you're not able to completely because of the stiff arteries. We've learned the stiff arteries are also a marker for increased cardiovascular risk. What's still unclear, not everyone with a stiff artery has PAD underneath, but probably about half of the people do. And what we don't know at the moment and is still being worked on is whether the increased risk due to a high ABI is just due to the subset with underlying PAD or there's something about the stiff artery itself that indicates risk.
How do we measure ABI?
So technically it's been done a lot of different ways, but the most reliable way is to use blood pressure cuffs, the correct size for the arm, the correct size for the leg, and to use a handheld Doppler to determine the pulse. We're all used to taking the blood pressure in the arm with the stethoscope. The Doppler is actually a little better. It's a little more accurate. At the ankle, the stethoscope is very inaccurate, and you have to use the Doppler, and we have to actually check both the posterior tibial artery and the dorsalis pedis artery. So basically, we simply measure the pressure at both arteries in the right ankle, and the higher of those two pressures becomes the numerator for the ABI. We measure the pressure in both arms. The higher of the two arms becomes the denominator for the ABI. So for the right leg, it's the highest of the right ankle pressures divided by the highest arm. For the left leg, it's the highest of the two left ankle pressures divided by the highest arm. One of the reasons we use the highest arm, you say, well, if you're measuring both arms, why not take the average and reduce variability? The problem is that there's an association between subclavian stenosis and PAD. So if you take an average of the pressure, you might be averaging in a falsely low pressure. And even worse, if you were to just randomly select an arm and take the blood pressure, if you pick the one subclavian stenosis, you're going to get a falsely low arm pressure.
We've tried measuring ABI as a screening parameter for retired football players. And our initial experience was that there just weren't many folks, 50-year-old, 60-year-old football players who had reduced ABI, and these are asymptomatic people who are just looking for cardiovascular disease. So I'm not sure that we were using the ABI right. So in whom should an ABI measured as a primary tool for determining cardiovascular risk?
Well, certainly the ABI is not to be measured in everyone. It's not like a cholesterol level or blood pressure where you start very young. You don't see abnormalities until middle age and later. And even up to the age of 60, the prevalence of an abnormal ABI is only 3 or 4%. So you really need to target an older population or a high-risk population. So the current AHA, ACC recommendations specify that people older than 70 years of age should routinely be screened. People between 50 and 70 who have diabetes or have a history of cigarette smoking should be screened because those are very potent risk factors for an abnormal ABI. And then, of course, anybody that has exercise leg pain, no matter...
A symptomatic patient.
Symptomatic patient.
So there is some truth to the adage that cholesterol goes to the heart, blood pressure goes to the head, and smoking and diabetes go to the legs.
There certainly is specificity of the cigarettes and smoking and diabetes for PAD. However, hypertension is also a risk factor. Lipids are also a risk factor. Lipid treatment is very beneficial in PAD. But there certainly seems to be a little bit of specificity for the risk factors. That's correct.
All right. Let's say we have an asymptomatic individual comes out with a ABI of 0.8. Is that going to be a surprise to us that they're asymptomatic? And what do we do about it?
No, it's not a surprise because we found that more than half of the patients who actually have PAD have a major artery in the lower extremity, 50% or greater stenosis, do not complain of leg pain. That doesn't really mean they're asymptomatic. What we've learned now through many studies is that some people will complain of numbness, of weakness, of tiredness in the legs. And when you actually challenge them to, say, do a 6-minute walk, a standardized 6-minute walk, you'll find many of these people do develop quite a bit of what they'll call discomfort. And so a lot of the people that are, quote, asymptomatic aren't really asymptomatic. And the other thing is a lot of those people are very limited. And if their PAD was identified and they were put on an exercise program or the appropriate medical regimen, we think function could be improved. So we don't think that not reporting exercise leg pain as a major complaint means that the person doesn't have PAD. It may not even mean that they don't have limitations from PAD.
So let's return to our patient, asymptomatic, 0.8 ABI. What do we do next? Obviously, you want to look at the legs, but do we want to go elsewhere? Do we want to look at the heart? Do we want to do a calcium score? Do we want to do a stress test? What do we do?
Well, the idea of doing a calcium score and a stress test is very debatable because the feeling with a 0.8 is pretty unequivocal PAD. If the ABI is 0.93 or 0.94 or 0.89, you may want to do a stress test to verify that there's PAD, a stress of the leg, either a treadmill or a toe rise test to see a blood pressure drop and make sure PAD is really present. But then if PAD is present, we think they deserve the maximum medical therapy. They basically, based on the National Cholesterol Education Program ATP3 guidelines, they have the same objectives for lipid levels. They deserve antiplatelet therapy. They deserve aggressive control of hypertension. And we also think that they particularly benefit from an exercise regimen if they have PAD. That's unequivocal. Now, should you do a calcium screening? That's the debatable part. Should you take someone down the primrose path to revascularization if they're already getting maximal medical therapy without any cardiac symptoms? And that's where it's debatable. And now that we know that, even with stable, this is going out of my area and your area a little bit, but even with stable coronary disease, that probably elective PTCA doesn't add to the benefit of the patient above medical therapy, I think we'd be a little bit cautious about going for these screenings.
So exercise has a particular place in the individuals with low ABI. Let's say we have a patient with coronary disease, and again, perhaps because of angina, he's pretty limited in what he does, and we get an ABI, and now we're down at a 0.5, 0.6 level. What does that tell us? What do we do?
Well, most patients with or without coronary disease who have an ABI 0.5 or 0.6 will either complain of exercise leg pain or will be very limited in function if you actually challenge them. Say, while you're treating them optimally medically anyway, what difference would it make? Well, it may be of interest to the patient that additional identification of an ABI in that range substantially increases their risk of another event and mortality, even beyond the risk conveyed by their known coronary disease. And they're particularly a good subset to introduce exercise therapy, to do regular supervised exercise. That will not only improve their ability to walk and function with their lower limbs, but it will also improve their overall cardiovascular health and lessen their probability of a coronary event for that reason. And you also, if they're symptomatic, may want to add medical therapy. There are medical therapies available. The only one that's really beyond exercise, which is the best medical therapy, cilostazol, is an effective drug.
So that reinforces the concept that if you have coronary disease, it's not a good thing to also have peripheral vascular disease.
Absolutely not.
That's a bad prognosis. All right, if people want to read guidelines or more about this, where should they go?
PAD guidelines have just been updated, and they're published both in Circulation and JACC.
Michael, it's been a pleasure to have you with ACCEL.
Thank you, Bob. It's been a pleasure as well.
That brings us to the end of Disc 2. For details about studies discussed, refer to the written summary that's included as a PDF file on Disc 3, which begins with a discussion on biomarkers in ST elevation MI, a tool in search of an application,